now we have we have 23 participants, and so I'll get started with this, and we'll let Dr. Cole take over after this. So I've got just a couple little housekeeping things to say first. Good morning, all, and welcome to this Ask the Doctor morning Zoom discussion with Dr. Craig Emmitt Cole. Dr. Cole is Assistant Professor, Division of Hematology and Oncology, Clinician, MSU Breslin Cancer Center, Michigan State University. A board-certified hematologist who completed his undergraduate degree at Michigan State University and his doctoral degree at Ohio State University, Dr. Cole began his postdoctoral training in internal medicine and hematology oncology at the University of Michigan Health System. He has had the opportunity to do post-fellowship laboratory research in the Jerome Lipper Multiple Myeloma Cancer Center of Medicine at Dana-Farber Cancer Institute, Harvard Medical School in Boston. This opportunity then led to a staff lectureship at University of Michigan, concentrating on primarily on clinical research in multiple myeloma. Now, Dr. Cole is back at MSU, where he began his studies. Before we begin our discussion, I'd first like to thank our very important partners. Can you see that? Bristol Myers Squibb, Amgen, Adaptive Biotechnologies, Karyopharm Therapeutics, Takeda Oncology, and Dova Pharmaceuticals. Without them, we wouldn't have the resources to reach out to multiple myeloma patients and provide this great discussion platform. I also want to introduce Sid Moss to those of you. I think everybody knows who Sid is, but I want to just let Sid speak for a minute or two if you'd like, and you can thank Sid for those great Wolferman's Bakery breakfast boxes that you received. So do you want to say a couple words, Sid?
Welcome, everybody. Thank you for joining us this morning, especially Dr. Cole. I think those of you who know Dr. Cole know he's not only a brilliant clinician, but he's very passionate about what he does, and he's a great speaker. So welcome, Dr. Cole.
Well, thank you. I'm so happy to be here.
So this is the way it'll work. Dr. Cole will provide us with a little background on himself for those of you that don't know him. Then he'll give us an update on multiple myeloma treatments and any other news as it relates to multiple myeloma. We have an hour or so, so once he's kind of done telling us all that, we'll open it up to questions. I've got a couple questions from the group, but you can please use your chat button to, oops, I got it, somebody waiting, to ask a question, and I will check the chats and read off questions. Once we're done with all the questions that we've got here, then we'll open it up and let you ask questions from the floor. So again, thank you for taking the time for the Zoom session, and take it away, Dr. Cole.
Thanks. No, thank you for inviting me. I think I've been doing this for, I think as long as you've been doing it, like a couple of years, I think, and including the wine and dine and the D and everything. And so, I'm happy to be here. I think regarding me, I think you said everything. So that I got to Michigan State, and I run the clinical trial program there. And the very first thing that I did when I got to Michigan State was open a clinical trial using the new antibody drug conjugate, blinatumomab, which everybody in the myeloma, in fact, I was at a teleconference through the MMRF Saturday, and everyone is pretty excited that blinatumomab is going to be approved, likely to be approved by the FDA, hopefully in the next couple months, for relapsed and refractory myeloma. And so one thing I wanted to talk about was because you're going to hear about blinatumomab in the very near future, is about that drug for relapsed refractory myeloma. Back in 2015, The first antibody was approved by the FDA for multiple myeloma. That antibody was daratumumab. And daratumumab is a classic antibody for multiple myeloma, that the myeloma cell has receptors on it. And Mickey, do you know if I can share, can I share slides on, here, wait 1 second, because
Yes, you can, if I believe you can just share your screen.
okay,
you have
let me, because I can show you a little cartoon. Hold on 1 second.
Now you can talk.
Shall we can't hear Dr. Cole. I
We can't-
see Dr. Cole.
he just changed to try and share his screen. So,
Well, he wasn't on before.
well,
Yeah.
I can see, can everyone see Dr. Cole besides Sid?
Everybody important can see him. Okay.
And
We've got that one open spot.
show you a little thing about this new drug, but it is again one of the newer or newest drug for myeloma, and let's see if this will work. Share screen. So if I hit this button, it should. Oh, you have to disable the, Mickey, you have to disable the screen share.
Okay, let's see. How do I do that?
And
Oh, I can make you a host. Would that work?
yeah.
Okay. Okay. There. Now you're the host. You should be able to share your screen. Yep.
So these are the antibody drug conjugate. Can you see the screen?
I can. Yes.
Okay. So these are the antibody drug conjugates for myeloma. And so here's the antibody. And so daratumumab is an antibody built just like this, and elotuzumab, or Implicity, is an antibody built just like this without having the little chemotherapy linkers. Blintamumab is different because it has these chemotherapy drugs attached to the antibody. And that's what makes it a second generation monoclonal antibody for myeloma, is that it's not only just a naked antibody, but actually has chemotherapy drugs attached to it. If I injected that chemotherapy drug into somebody, it would make somebody, or would make me really sick. However, attached to the antibody, it is inert. And here's a myeloma cell, and the new protein that is the new target for lots of drugs, CAR T, the BiTE antibodies, which we can talk about a bit later, and the blintamumab is BCMA. And BCMA is a protein only on myeloma cells. In fact, I can show you that here is a graph of the different organs in the body and how much BCMA they have on it. And hands down that plasmacytomas and myeloma have the most of this protein on the myeloma cells. And really there is hardly any other cells in the body that have this protein. So it makes it an incredibly good target for drugs to treat myeloma because it's only on myeloma cells, which means that when this antibody attaches to BCMA, the antibody will only attach to myeloma cells. So once the antibody and the drug conjugates attach to the myeloma cell, then it's brought inside the myeloma cell, so it's incorporated, and the chemotherapy drug dissociates off the antibody and it kills the myeloma cell. The other thing is that because it's an antibody, just like the first generation antibodies, like daratumumab and elotuzumab, that it also gets the normal immune system, the natural killer cells and the T cells, and the other immune white blood cells to also attack the multiple myeloma cell in the same way that the other antibodies do. So it gives it a 1-2 punch that is very unique for a very unique treatment for multiple myeloma. This drug is humanized, the antibody is humanized, and the chemotherapy portion is autostorin. And right now, in the clinical trials, it's given in a number of different ways. It's either given every 3 weeks or every 2 weeks. But in the phase 1 study that was done with this drug, in patients that had more than 5 prior lines of therapy, the overall response rate was 66%, which really is an exceptional response rate for patients that have had so many prior lines of therapy. And probably the big thing about this drug as compared to some of the other BCMA targeted drugs is how long the duration of response was. That the duration of response is 14 months. And I think I can show you a graph where actually some of the responses went out much, much longer than that. And including looking at the responses that really the responses just weren't, partial remissions. There were a number of VGPRs, 90% reduction in myeloma burden, and complete remissions, again, in patients that have had multiple prior lines of therapy. And because of that activity is the reason why they brought it to the FDA and why everyone is anticipating its approval for relapsed refractory myeloma. It does have some side effects, and probably one of the most prominent side effects, which is very manageable, is that it can cause the cornea or the eye to get very dry. And if it gets too dry, then it can cause damage to the eye. And so what, at least on the clinical trial, a lot of that dry eye or the corneal damage is alleviated with using eye drops and with some dose modifications that they made to the drug. And so the patient that we had on trial didn't have any eye problems. And most of the eye problems that are reported for this drug were only seen by ophthalmologists and not noticed by patients. The other side effect that we saw and that is reported are low blood counts and specifically low platelet counts. And they never required transfusion. They were, pretty, the count went down, but we didn't have to make any dose changes. And cough. And I really see when we've treated patients, I really didn't see any cough associated with it. And the really good thing is that the infusion isn't as long as some of the other drugs. And there are very few infusion reactions that are reported. And so it got breakthrough designation. And again, it's going to the FDA. The DREAM-6 study, which is at Michigan State and was recently at the last American Society of Clinical Oncology meeting, was also really exciting because they reported the results of this study, which combines the blintanumab antibody that I just talked about with either Revlimid and dexamethasone or Velcade and dexamethasone. And the Velcade, and combining this drug with Velcade dexamethasone actually had very good response rates in the order of 70% with the addition of Velcade and very little in the way of additional toxicities. And so, in fact, that arm has done so well that it sounds like we have a meeting later today. The study group has a meeting later today where I think that that people again are really excited about the Velcade dexamethasone arm of that trial, and may be the arm that will be moving forward into more studies. Yeah, and so that's one of the things that I'm excited about a lot of stuff, but that's one of the things that I'm really excited about in the myeloma space. The other thing that, gosh, there's so many other things that are going on. The other thing I think is really exciting in regards to the first generation antibody is that daratumumab has been approved by the FDA as a subcutaneous infusion. And Dara was, again, one of the first antibodies that came out. And again, it was approved in 2015 and has really been our go-to drug, not only in the space of relapse refractory myeloma, but now it's been moved up to first-line treatment for myeloma. And daratumumab has been approved for upfront therapy for myeloma in the way of two regimens that we don't use too much. Daratumumab combined with thalidomide, Velcade, and dexamethasone. And it was also approved for daratumumab, melphalan, Velcade, and prednisone. And those regimens, the backbone of those regimens are drugs that we don't use very much. We don't use melphalan as upfront therapy for myeloma or thalidomide as upfront therapy for myeloma very much. But then later in late in 2019, I think it was in September or November, daratumumab plus Revdex was approved for upfront therapy for myeloma, with really remarkable response rates for newly diagnosed myeloma. I think the super exciting thing is that now there have been studies on 4 drug combinations for upfront therapy for myeloma. And if I can show you a little slide that if it's like, Mickey, can I show a MMRF slide that I made?
Yeah.
Yep.
Sure.
Let me show you another slide. And I'm just going to show just one slide about this new upfront therapy. There we are. And it's kind of a summary slide that I'll kind of whittle through. There and there and there. There we are. And so I think that in screen share. There we go. Screen share, and we're going to look at this slide. And does everybody see the slide? I hope. So, right now, the standard induction therapy for myeloma is Revlimid, Velcade, and dexamethasone for newly diagnosed myeloma. There really is, I think that in the very, very near future, that we're going to use 4 drug induction therapies for myeloma. And in fact, and I put and in the summary slide, I showed some data on the new 4 drug therapies that are in clinical trials for myeloma. And kind of what prompted that not only were the outstanding results of using daratumumab plus RVD versus RVD, there was a randomized trial where they got at Emory University, where they got patients with newly diagnosed myeloma, and they either received the standard of care, RVD, which is what everybody uses basically to treat newly diagnosed myeloma, and half of the study population had the addition of daratumumab to their RVD. And it's a study to see, can we improve upon the standard of care right now? And they actually reported this in Blood, I think about 3 months ago. And really everyone's super excited about this, because when you look at the DARA RVD versus standard RVD, getting just RVD, incredible response rates. That newly diagnosed myeloma patients, when they receive RVD, the expectation is that over 90% of patients will get a response to the therapy, which is fantastic. However, with the addition of DARA, that's pushed to 99%. What's really impressive is how deep the responses are. That at 2 years after they had a therapy, that there were still 62% of patients were in a stringent complete response, which means that not only do they not have any protein, myeloma protein on their blood tests, but on bone marrow biopsies, they can't find any plasma cells. And again, you look at the DARA RVD versus standard RVD at 22 months, that with DARA RVD, that 62% of patients are in a stringent complete response. MRD negativity, which we can talk about a bit. MRD which means that you can't find any myeloma cells in 10,000 normal cells, that there are very few, if any, myeloma cells based on the most sensitive measurement that we can make on a bone marrow biopsy. Again, 51% of patients MRD negative with DARA RVD, and the 2-month progression-free survival, which means that how many patients at 2 years were still in a response, and 95% of patients with the addition of DARA remained in maintained their response. And again, a lot of those patients that had a response were having complete remission. So at 2 years, 95% of patients maintained their response. And then you look, which I think, and if you look at Mayo Clinic has something called the MSMART guidelines. And I think, most myeloma doctors look at msmart.org to see how, what really it's a consensus of what a lot of myeloma doctors say, but it's kept at the Mayo Clinic website. And when you look at their recommendations for the treatment of high-risk myeloma, they have just recently, in the past couple weeks, changed their recommendation for high-risk myeloma to using DARA RVD. And I think in part it's because of the incredible responses that they've had. And here are some of the other antibodies that are combined with standard induction therapy. DARA KRD for newly diagnosed myeloma, response rate 100%. And most patients had very good or complete responses. DARA Ninlaro Revdex, again, excellent responses. Isatuximab, the other CD38 antibody, again, incredible responses. and it's ixekizumab KRD for high-risk myeloma that was presented at the middle of June at the EHA meeting. Again, incredible responses. And so, and that's, what I'm really, really excited about is the use of these antibodies as upfront therapy for myeloma. Not only have we done so much better by moving from melphalan and prednisone back in the, let's say up until in the 1990s, which had a 30% response rate. Now having really our standard induction therapies pushing 99% to 100% response rates, which is an incredible, in my career, back when I had hair and was thinner, when we were giving, I remember telling a patient, one of the very first patients that I saw as a resident, and we told him, we gave this patient melphalan and prednisone. I think I was a resident, and we told him there's about a 30% chance this is going to work. And if it doesn't work, the only thing we have is another chemotherapy regimen. And to go from 30% to, regularly 99% to 100% in just 20 years, I think is pretty incredible. So that's what I'm excited about. I got a lot of other stuff I'm excited about, but I don't want to bore you with it.
I don't think you're boring us at all, Dr. Cole. This is all really exciting to have treatments that show such great response. I mean, I think that's wonderful. Do you want to go on and tell us a little bit more about other things that you're working on right now, or should we start asking questions? What would you like to do?
How about we start asking questions, and I'll probably branch out into talking about other things along the way. But I want to make sure we get to the questions for sure.
Here's one question. It was brought up at a meeting I went to that all of us in the room with myeloma had different types. With the drugs that have come out in the past few years and are currently or shortly coming out, how does a patient know which is the best for their particular myeloma?
Wow, that's a fantastic question, and something that I've been, incredibly passionate about. So what's the downside of all of those therapies that I showed you? What's the downside? The downside of all these 4 drug therapies is that they took all comers with myeloma and put them through that therapy. That they didn't distinguish, they didn't make any decisions based on their diagnosis. They said, you have myeloma, we're going to treat everybody with this. The fact of the matter is that some of those patients, as you saw, some of those patients could respond incredibly well to just 3 drugs. Some of those patients, I'm not recommending this, some of those patients would respond to 2 drugs. There's a lady, a super sweet lady, when I did a talk in Denver about 4 years ago, and a very, very sweet 90-year-old lady came up to me at the myeloma conference and said that she's been in a remission for 20 years and that she was treated only with dexamethasone. And I said, no way, that's impossible. You can't just get steroids and have a remission for 20 years. And I said it I didn't say it like that, but I said it in a nice, kind manner. So the next year I was there and she came back and she had her bone marrow biopsy that was on this, frail piece of paper that said, here's my bone marrow biopsy from, from the 80s. And I'm showing you that I had multiple myeloma and I'm in a remission from dexamethasone. And what that told me is that what we know in myeloma is that there are different types of myeloma. And that's absolutely true. Right now, the way that, right now we only have 2 different types of myeloma. Right now, using the technology that we have. There is high-risk myeloma and standard-risk myeloma. We know that there are more different types of myeloma than just those two. It's like saying there are bald people and there are people with hair. Yes, you can tell the difference between those two, but there are a lot of differences in people with hair, and there are a lot of differences in bald people. And how do you make that distinction with myeloma? Well, the COMPASS trial has been working on that. And the COMPASS trial is when they get newly diagnosed patients, this is the MMRF, they get newly diagnosed patients, and then they do molecular sequencing on their myeloma. And using technology that is able to distinguish the different types of myeloma, not based on how the myeloma cells look, not based on the protein level, not based on the gross cytogenetics, but based on the molecular mutations that led to the disease for that individual. And when you use technology from, you use technology from 2019, 2020, we're beginning to see that there are different types of myeloma, not based on some of the gross testing that we used to do, but based on molecular testing. And the trick with that is that we have to follow those patients for a long period of time to see the different branches, to see that there's some patients that will relapse very quickly with myeloma when they have certain mutations, especially in a transcription factor called P53, or a protein called P53. There are other types of myeloma patients that, just like the lady in Colorado, that only need minimal therapy, that will do perfectly fine. And so the trick with myeloma, and that has been a very difficult nut to crack, is to be able to distinguish between those subtypes. A molecular geneticist, Jonathan Keats, he runs the COMPASS, he does the molecular diagnostics for the COMPASS study. And I sat down next to him at a meeting, and again, I think I'm a nice person, but I was like, Jonathan, what's taking so damn long with being able to distinguish these subtypes? And he got a little angry and said how frustrating it is that he was able to do this for other types of cancer very quickly, and that myeloma is a really difficult disease to do this in, that the plasma cells don't give up their secrets as easy as other ones. But I would say that we are getting closer and closer to making that distinction. Right now, we have just at the last ASCO meeting, and very recently, over the past 4 years, we now know that there's a subtype of myeloma where patients will have the 1114 translocation. And I think I have a slide on that, but I'll just describe it I'll show you a slide on it. But and I can talk while I find the slide, but the 1114 translocation will express a protein called BCL2. And BCL2 is a protein that keeps cells alive. And in myeloma, and only about 10 to 15% of myeloma patients will have in their myeloma cells a translocation of chromosome 11 and 14, where the two are stuck together. And when patients have a lot of 1114, they don't have that message for the plasma cells to die, what happens? They keep on living. And that's kind of the definition of cancer, is cells that divide and won't die. And so patients with 1114 that overexpress BCL2, in a clinical trial that was done at Mayo Clinic and then subsequently done done in France also, they used a drug called venetoclax. And venetoclax is an inhibitor of BCL2. So here's a protein that keeps plasma cells alive, and there's a drug to inhibit it. And when they gave this drug BCL, or the venetoclax and Velcade to patients with myeloma, they had very good response rates, but especially in the patients that have 1114 and overexpressed BCL2, they had really good responses. And the trick with, and even in a study that was done by Mayo Clinic, even when they gave venetoclax all by itself, when they gave the pill all by itself to just all comers with myeloma, response rate was about 28%. When they gave it to patients that had BCL2 overexpression and had 1114 translocation, the response rate was in the 85, almost 90 percentile. And so, which is proof that this drug works for that particular subtype. And it really is it is the first molecularly targeted drug for myeloma based on mutation and not treating all comers. And that is really, and there are now other studies that are going on looking at molecular subtypes of myeloma to see if that proof of concept will work for other types of mutations. So right now, can I say that outside of distinguishing between high risk and standard risk myeloma, can we subdivide that group even further in using specific therapies? Well, the only way that we can get the standard risk patients and identify by their FISH cytogenetics if they have 1114 translocation. And again, about 15%, 10% of patients that have myeloma will have the 1114 translocation. And in that subset of patients that have 1114, then you can do staining on the bone marrow to see if they overexpress BCL2. And we just did that for one of our patients here who had relapse refractory myeloma. And we biopsied a plasmacytoma. And interestingly enough, the patient didn't have 1114, but I suspected that he has that protein overexpressed, the BCL2. And so I had the pathologist stain the plasmacytoma for BCL2, and it was super highly expressed. And so right now we're working on, because he's gone through a lot of prior therapies that have failed, we're trying to get venetoclax for him to treat his myeloma, because based on a lot of the data that shows how well patients respond when they're BCL2 overexpressed, we're planning on treating him with venetoclax. I hope does that make sense? I hope. It was a long-winded answer for a question that says that that you're right, there are lots of different types of myeloma. However, right now, using FISH cytogenetics and actually immunohistochemical staining, they were able to find one subtype of that is currently in clinical trials to treat with a specific drug. Someone on the chat asked, wouldn't the Cure Cloud further help define these subtypes? And yes, that the Cure Cloud that the MMRF is working on is also trying to help subdivide those patients and really to follow to see how patients do, because the primary way that we look at the CL myeloma patients do and diagnosed are through the SEER registry. That's the NCI's registry for cancer that are at the major academic centers across the country. But that only captures about 30% of people in the country. And so the Cure Cloud is trying to cast a much larger umbrella to get a better idea of what happens to patients with myeloma, and will help us be able, because the umbrella is hopefully so wide, that we'll be able to find those subtypes. And you're right, in the future, be able to direct therapy to those subtypes in the same way that we do that for the 11-14 and BCL2 types of myeloma.
So the Cure Cloud was going to be the next question. Can you, I don't know if everyone knows what the Cure Cloud is yet because it is so new. Can you talk a little bit about that and what the expectation is of that?
I can. In fact, I am certain that they're not going to be mad at me if I use their, so let me show you. This is from the screen share, and there we are. And this is from the patient summit that we did just over the weekend. And the Cure and the Compass study, which I had mentioned earlier, where they did, where they got over 1,000 patients with myeloma and did sequencing that actually dates back, I think, to 2015 or 14, which is where the technology was, a bit, it was the best technology at the time, but was a bit dated. But they, we got the hint of different subtypes of myeloma. Then at U of M, when I was there, we had worked on a molecular profiling protocol for relapse refractory multiple myeloma to get an idea. Well, the Compass study was getting an idea of what newly diagnosed myeloma patients look like. The molecular profiling protocol actually used a more directed approach at looking at mutations and relapse refractory myeloma, and in patients that had poor responses with newly diagnosed myeloma. And that then led to the Cure Cloud, where instead of going into to one of the MMRF centers, part of the consortium, that you can actually do the Cure Cloud from any clinic, anywhere in the country. And that's why they're expecting so many more patients. So while the Compass study gave the genomic subtypes and definition of high risk, and actually helped us come up with the new targets, and including the P53 mutations and alterations that I had mentioned earlier. So now the Cure Cloud is looking at subtypes, and instead of me doing a bone marrow biopsy and then getting the data myself at a consortia site, this does it, and you get that data, and your doctor gets it from home. It's also going to look at smoldering myeloma, which was something the Compass study had excluded. And it is not only going to look at mutations inside the myeloma cells, but also look at, well, what is your immune system doing? Because now that the future, as I showed you earlier, is really going to be about therapies that use the immune system, it's now a good idea to understand the health of the immune system in myeloma. And so and I can show you, I think, that what it's going to do, again, is do an immune profiling of myeloma patients. And what you would be able to do is just send in a blood sample. That with the blood sample, they're able to pick up in patients that have active myeloma. So their M protein has to be above 0.3, and their light chains have to have a ratio greater than 10. And if they have that much, which isn't a lot, myeloma, then they have free-floating bits of DNA from the myeloma cell floating in the bloodstream. And they're able to do the genomic testing based on a blood test, instead of having to get bone marrow biopsies and things like we did for the COMPASS study. And what the other thing is that you can do it from anywhere. So I thought they had no, they did. I thought they had a picture of, no, but they will have, what happens that you can sign up for via their, the website. So MMRF Cure Cloud, or you can call the number. They will send a test kit to your house. You and a consent form. You sign the consent form and you take the test kit and the requisition for the blood test to your doctor's clinic. Your doctor clinic also signs off on it. They draw the blood, they put it in the kit, and they send the kit to the MMRF. And the MMRF then does the genetic testing. They then contact you to receive more information about your course of myeloma and what's happened. And then they will then give you the report of the genetic testing to you and your doctor, which may not be actionable today, but could be actionable in the future. And it will give us more information about myeloma patients for the future, about the subtypes that I talked about. And so that's the Cure Cloud in a nutshell. Kind of a nutshell.
That sounds really, really exciting. And I think that, that it's something that we can all look forward to understanding a little bit more about this when they have all this information compiled. So, are there any prerequisites to this, or do you encourage everyone here that to research it and figure out if they're eligible and then go ahead and do it?
Yeah, I would. The big requisites is that there has to be some measurable protein on the myeloma. There has to be some measurable protein in the blood. And so patients that are in complete responses or have very little in the way of myeloma cells, they wouldn't be eligible because you just can't pick up enough of the cells on of the molecular pieces of the cell on a blood test.
Okay. Here's one question that came in. I have deletion 1p. Does that mean I am considered high risk?
It's a good question. So just about 3 or 4 months ago, it may have been longer than that, more like 6 months ago, we reclassified trisomy, so 3 copies of chromosome 1, as being high risk. In part because some patients that have trisomy, 3 copies of 3, do have a bit tougher of a course with myeloma, and that it can relapse sooner. Not true for everybody, but it can relapse sooner. Deletion 1 has been kind of interesting because deletion 1 originally was kind of put in the same bucket as saying that it has a similar course with trisomy 1. But over the years, as we've been treating patients with myeloma, that deletion 1 doesn't have the same gravity that trisomy 1 has. The deletion 1 and having hyposomy or deletions of chromosome does increase the risk somewhat, but it doesn't have it to the point of that the trisomy 1. So is it high risk? It's not necessarily, it's not high risk. The trisomy 1 is really the high risk part.
Another question came in. Do you routinely measure MRD in your patients outside of a clinical trial?
I don't. But I have come very close to doing it. And usually when I mention that we have to do a bone marrow biopsy to do the MRD measurement, then patients get a little bit turned off. In part because I don't know what to do with the information yet. That I don't know, because the big question is, well, can I stop maintenance therapy if I'm MRD negative? If I have no measurable disease by any method, do I have to stay on the maintenance therapy? And we just don't know the answer to that. We're getting some strong hints about it, but we don't know the answer to that. And does MRD negativity mean that the disease will never come back? We're finding out that MRD negativity isn't a sign of a cure. It's a sign that the disease would take a much, much, much longer time to come back. But it's not a sign that if you're MRD negative that we can discharge you from the clinic and we'll never see you again. And so because there's not a lot of decisions that I can make with MRD right now, that may be different in the next 3 to 5 years, but I don't check it routinely because there's nothing I do with the information.
Okay. A couple other things that I know are on patients' minds right now. One is, with this COVID-19 pandemic, are there any recommendations that you have for multiple myeloma patients that might be, particularly, like something that they should do or shouldn't do because they've got to navigate around this new disease?
Yeah, I'm glad that that you mentioned that, because what we definitely know is that patients that have cancer have a high risk of having the bad reaction to the COVID virus. So the really scary thing about the COVID virus is when people have that cytokine release, or when they have the severe inflammatory release syndrome, which has patients with COVID end up on the ventilator and in the ICU. We know that patients that have cancer have a higher risk of that because of their weakened immune system. And so, the general recommendations for patients with cancer with COVID is that, is to make sure that cancer patients are aware that COVID infection is a bit higher due to their weakened immune systems, and that we definitely stress the need to adhere to the recommendations to prevent infection, including social distancing. There was recent data saying that on some surfaces that COVID can last for a few hours. And so cleaning surfaces, washing hands frequently, I can't underemphasize that enough, using the masks to especially, and encourage the mask use so that patients who are asymptomatic aren't delivering the virus. Avoiding travel except for treatment, and limiting context. Regarding therapeutic decisions, we've been doing that on a case-by-case basis. We have been leaning more towards oral therapies instead of IV therapies in order to minimize patients coming into the clinic. And dexamethasone, as in its oral use in patients without COVID, does make them a bit more susceptible to COVID infections. And so we usually try to reduce the dexamethasone dose as best that we can, but making sure that we maintain adequate therapy. And so, we do telemedicine as much as we can. I've been doing that, and I love doing telemedicine for patients, so they don't have to travel. And we've been using, trying to ask the insurance companies to give us longer prescription renewals. And so instead of giving, 1 month of dexamethasone at a time, that we're giving 3 months, and so they don't have to go into the pharmacy and such. And so for the smoldering myeloma patients, they do have some increased risk, but we're not really sure how much. So for smoldering patients, there are some people that say you can treat them. During COVID, we haven't been treating smoldering patients. And we've been delaying stem cell transplant on some patients. And again, we've been trying to use as much oral therapy and as much telemedicine as we can. But, I would follow the local recommendations, definitely have good conversations with your doctor, and really, adhering to the social distancing and the mask wearing to try and prevent infection.
One more, it looks like we're just about out of time, but I have another question. When defining the number of therapies you have been on, does an SCT count as one of them?
So what we usually, so stem cell transplant is usually part of the first regimen. So you get induction therapy, transplant, and maintenance is one single thought of therapy. So it's all upfront therapy. So when a patient has induction therapy, transplant, maintenance, that's one line of therapy. If they relapse and get a second transplant, the relapse therapy and transplant are a single line of treatment.
Does anyone else have another question? If you want to unmute yourself and ask a question, I've kind of run through all the questions so far. So, and actually it's time too, but does anyone else have anything specifically they want to mention? Yep. Hal, here, unmute yourself, Hal.
I was wondering if IVIG therapy will help protect us from COVID-19.
That's a super good question. And the folks and I'm probably going to reserve my answer to see what the folks in New York are going to say. And so Joshua Richter and some of the other myeloma doctors at Memorial Sloan Kettering are going to put out a paper, I understand, the next few weeks about their strategies of treating myeloma patients with COVID in New York, what their experience has been. And which is, I think incredibly brave of them to, to have, because they were on the front line of when the virus first hit. And Josh and I are, Facebook friends, and we have been communicating about how things are going for him there. And so they've collected a lot of data and strategies that they use to treat and prevent COVID. And my understanding is they're going to have that published very soon. So so right now, we don't know. But I'm hoping that we'll know a lot of things soon in the next few weeks to maybe a month.
Oh, that's pretty exciting. It'll be interesting to find that out.
Yes, very much so.
Does anyone else have a final question for Dr. Cole? Well, then I just want to say thank you so much for taking the time to do this, Dr. Cole. We really, really appreciate it. It's nice to have a whole hour where we can learn a little bit more, and we are very, very appreciative of this and of your time.
That's no problem at all. I'll be back any day. Now I got to pick up some Legos. So.
Okay. All right. Okay, good. Well, have fun with your Legos.
Okay, thank you.
Take care,
Have a good
everyone.
day, everybody.
Have a good day.
There it is.